terms of objectives, first we want to identify the dehydrated child. Then we want to determine candidates who are appropriate for oral rehydration. And then we determine what is the appropriate fluid for oral rehydration. And then describe or choose appropriate bolus and maintenance intravenous fluids for children who are dehydrated. Pediatric dehydration, particularly due to gastroenteritis, is a common emergency department complaint. There are approximately 200,000 hospitalizations in the U.S. for gastroenteritis in the pediatric population, and there are estimated to be about 300 deaths per year secondary to severe dehydration. Throughout the world, this is a much more serious problem. For children under the age of 5 years, the annual incidence worldwide of diarrhea or gastroenteritis illness is approximately 1.5 billion. And they're estimated to be between 1.5 and 2.5 million children who die from dehydration. Although these numbers are truly staggering, you have to realize that in the early 80s, this number was 5 million deaths per year from dehydration. Infants and young children are much more susceptible to volume depletion, but as long as they do get IV fluids, they tend to recover very quickly, and they have a great prognosis. The morbidity from dehydration certainly is dependent upon the extent of dehydration. The more severe the volume depletion is, the higher there is a risk for cardiovascular collapse and death. You can also get hyponatremia, especially in a situation where you have a dehydrated child who's getting just free water alone and therefore diluting their sodium. And this sort of an improper management of volume depletion can cause additional complications such as seizures from a severe acute hyponatremia. When a concern for dehydration arises and you're trying to get a history, your goal is to really determine how severe is the dehydration, because the severity of dehydration is obviously going to impact your treatment. Generally, dehydration is divided into mild, moderate, or severe based on signs and symptoms. In terms of history, important parameters that you need to cover are feeding patterns and the amount of fluids that have been given, let's say, in the last 24 hours. You want to ask them about number of wet diapers compared with their normal. That gives you some sense of the ongoing fluid loss. So does the number of times they vomited and the amount of vomitus that came out. Also, you want to get a sense of their activity level, the current medications they may be taking, and obviously any other kind of environmental exposures, which is especially true in the third world, of course, excessive heat, etc., which could be adding to their ongoing losses. Just want to point out that systolic hypotension is truly an ominous sign for the pediatric population, because they tend to maintain their systolic blood pressure until they're almost at the edge of cardiovascular collapse. So that's truly an ominous sign that you should pay attention to. And this slide covers the formula for determining or estimating a normal blood pressure for a child. Review of the normal vital signs is kind of important, because that's your guideline to what is normal and what is abnormal. In terms of normal vital signs, this slide shows the newborn to 1 year old. The normal heart rate is around 140, and the respiratory rate is around 40. And then you can, between 1 to 4, heart rate is generally about 120 or so, and respiratory rate is 30. And from 4 to 12, heart rate ranges around 100, 90 to 100, and respiratory rate is about 20. And over 12 tends to be much more like an adult. Blood pressure in children, I know generally we don't pay that much attention to it, but the point really is that once they start to have hypotension, that's a truly ominous sign, and signifies cardiovascular collapse. To get a rough estimate of what is a normal blood pressure in a child, you take their age in years, you multiply it with times 2, and then you add 70 to that, and that'll give you an idea of what their systolic blood pressure should be. And then for the newborns, generally over 60 is considered normal systolic blood pressure for them. For a 1 month to 1 year old, around 70. And for over a year old, formula really applies that I just mentioned. So if you have a 5-year-old child who comes in um, with a blood pressure of 65, um, you would need to know what their normal blood pressure is, and their normal blood pressure should be around 80. So for that child, that's a significant hypotension, and that's a serious sign for them. In terms of diagnostics, for mild dehydration, there's really no need to do any type of blood work. It's not going to help you. For moderate dehydration, you want to get a sense of the extent of dehydration and any accompanying electrolyte abnormalities. So generally a basic metabolic panel is helpful. You look at the bicarb to see if there's metabolic acidosis, and you look at the sodium and potassium. For severe dehydration, you want to obviously get a lot more diagnostic studies to get a sense of where things are. Serum electrolyte levels are important to determine sodium concentration, which can guide replacement therapy. Bicarb and potassium levels are also important because they assess the degree of metabolic acidosis from volume depletion and tissue hyperperfusion. And then you look at the BU and creatinine, which measures the renal function and the intravascular volume. The glucose measurements may reveal hyperglycemia or hypoglycemia. Venous blood gas measurements are indicated in patients with severe volume depletion. Serum pH provides a direct measurement of the acidosis and can give you a much better, clearer picture of what's going on. An elevated serum lactate level is indicative of tissue hypoperfusion and decreased oxygenation, which results from anaerobic metabolism. It may be helpful in cases of severe dehydration or sepsis. On urinalysis, the urine-specific gravity indicates the degree of volume depletion. In terms of management, first we will look at the oral rehydration therapy, which I will call ORT. ORT has been effective not only in the maintenance phase but also in the acute rehydration phase. WHO has promoted ORT vigorously throughout the world, and that has probably been one of the main reasons why the diarrhea-related deaths have had a significant decrease. And is responsible for improvement in mortality and morbidity throughout the world. What is the physiologic basis for ORT? Basically, glucose and sodium cross the intestinal mucosal brush border together via an enzyme SGLT1. So that's how they're coupled together. And also there's the sodium-potassium ATPase pump that drives the transport of sodium from the intestinal cells into the bloodstream and maintains the normal sodium hemostasis. And these pumps retain function even in severely dehydrated children, and that's the reason why oral rehydration therapy or ORT is effective even in severely dehydrated children. And the key point here is that in your choice of ORT, you're going to need to have some sodium and glucose present in order to take advantage of this coupling process of absorption of sodium in the intestinal mucosa. In terms of ORT options, this chart gives you some information about the content of various ORT solutions that are out there. The World Health Organization recommended solutions generally not available in the U.S., but it's a pretty good guideline. They have generally the higher osmolality solution has a total of 331 milliosmoles per kilogram, whereas the lower one has 245, which is very comparable to the Pedialyte, which is what is available to us in the U.S. And things like sports drinks like Gatorade has an osmolality of 330. You look at the glucose content, the World Health Organization solutions range between 111 to 75 millimoles per liter of glucose. Pedialyte is closer to that, 130, and sports drinks tend to be higher. Look at the sodium content. Generally recommended sodium content is about 90 millimoles per liter, and the Pedialyte is about 45, and potassium is pretty stable throughout all of these. So generally what I'm saying is that if you want to stick to the guidelines set by the World Health Organization, for the ORT solution, and closer to for us in the U.S., Pedialyte probably comes closer to that. And sports drinks are generally, I mean, if you have no other option, I mean, in terms of Pedialyte, sports drinks are cheaper, and they can be used. They're generally not recommended for children younger than 2 years of age. They tend to have a higher glucose load, and they tend to have lower sodium, so that's just not a good idea. Then you look at in the bottom some sodas, colas, and 7-Up, and then the real terrible culprits such as orange juice and apple juice. And you look at the osmolality load in them; it's just enormous, and the content of sugar is really, really high, and the electrolytes are generally non-existent except for orange juice, which tends to have lots and lots of potassium. So they're generally not recommended as oral rehydration solutions, and they should be avoided. So generally, the recipes available on the internet to make homemade ORT solution should be avoided because they're just not reliable. Next, let's talk about instituting ORT. For normal volemic patients who just have ongoing losses from diarrhea, there is really no rehydration phase for them. All you're really doing is keeping up with their ongoing losses. So you begin by giving them 5 cc's of ORT solution every 5 minutes and increase it slowly. If they're less than 10 kilograms, you want to replace about 60 to 120 cc's per episodes of diarrhea or vomiting. If they're over 10 kilograms, you want to increase it to 120 to 240 cc's per episode of vomiting or diarrhea. Here we see what is done throughout the world. When children are dehydrated, they stay home and their mothers give them fluids through a spoon. 1 teaspoon is about 5 cc's and 1 tablespoon is 15 cc's. It requires vigilance and lots and lots of care, but that's the way people do it. ORT still has a role in mild to moderately dehydrated patients. Of course, there's a rehydration phase, and this is based on the CDC guidelines. You want to give them 50 to 100 cc's per kg of the oral rehydrating solution, and you want to give it over 3 to 4 hours and increase it as the child tolerates it. There's also a maintenance phase. It's the same as we talked about before: less than 10 kgs, 60 to 120 cc's per episode; more than 10 kgs, 120 to 240 cc's per episode. If after 3 to 4 hours of therapy the child has not deteriorated and symptoms have not worsened and is keeping the fluids, you can discharge the patient home with the same regimen. ORT also has a role in severe dehydration. It can be done. It is very common in the third world. You may need to put an NG tube into the child to get the fluids in. Generally, you would give them 20 mLs per kg of normal saline or lactate ringer until there's an adequate tissue perfusion and improvement in mental status. Those are your endpoints. Then you do maintenance as before. This is generally not used in the U.S. General contraindication to ORT are shock, altered mental status, or any problems with the bowel, such as a bowel obstruction or an ileus. So these are pictures that put a human face on the suffering that's related to dehydration and acute gastroenteritis. There are several barriers to ORT in the U.S. Generally, parents are not aware of this as a very legitimate option for rehydration. We're also a society of instant gratifications. We lead very busy lives. We don't always have the time to devote for ORT, which requires vigilance and constant fluids. They also, often parents think that vomiting is a contraindication for ORT. And then generally expectations from not only the patients, parents, but also from primary care physicians who send you these patients to the ER is that somehow you're going to give them IV fluids. And if you don't give them the IV fluids, parents are going to think that you're denying them something that is rightfully theirs. Actually, there was a study done in 2005 which looked at use of ORT in the emergency department. It was a randomized controlled trial that looked at ORT versus intravenous fluids in successful rehydration in children. What they found in that study was that Generally, ORT was initiated more quickly, 19 versus 41 minutes. There was no difference in improvement of dehydration scores between the two forms of therapy. Patients who had ORT were less likely to be hospitalized, 30 versus 48%. And there was no difference in overall patient satisfaction, which was 62% for the ORT group and 54% for the IV fluid group. So this just tells you that this is a viable option for you in the emergency department. When you do decide to use ORT, obviously you're going to use commercially prepared oral rehydrating solutions and not going to rely on the recipes on the internet to make your own. Just remember that rehydration can take 3 to 4 hours, which may be difficult in certain circumstances, but by the time you get the IV and etc., it amounts to about the same time. You also want to continue age-appropriate diet, which doesn't necessarily mean junk food and chicken nuggets, etc., but whatever is appropriate for that particular age group. And if the child is breastfed, that should be continued. You don't also want to dilute the formulas because that would reduce their caloric intake. And in general, most of this stuff is managed throughout the world with very little testing and use of clinical judgment. And so use your clinical judgment. Clinical judgment, if it's not exercise, is useless. So if the child looks well, and then give them a chance to hydrate themselves orally, and avoid sticking them and inserting catheters, etc., into them. Next, we're going to talk about the use of antiemetics in children. Certainly, a combination of antiemetic therapy and oral rehydration therapy are increasingly popular and kind of go hand in hand. Up until recently, there were really no safe options for antiemetics in children. Until the arrival of Odansetron, there really were no safe options available for children in terms of an antiemetic therapy. The phenothiazine, metoclopramide, they all had serious side effects and generally were simply not helpful in controlling these symptoms and were not effective in children. So Odansetron or Zofran has really been revolutionary therapy in that sense. Odansetron. Odansetron reduces the activity centrally and peripherally of chemicals that trigger nausea and vomiting. It is a serotonin 5-HT3 receptor antagonist. In part, it reduces the activity of the vagus nerve. The vagus nerve activates the vomiting center in the medulla oblongata. Zofran also does not have any effects on the dopamine or muscarinic receptors, which probably explains the safety profile. Oral Zofran for acute gastroenteritis was studied by Friedman in 2006. It was a prospective, double-blind, randomized clinical trial. Enrolled patients between 6 months to 10 years. They basically gave medication, which was followed by oral rehydration therapy. They found that patients who got Zofran had less vomiting and there was less need for IV fluids, even though the rate of hospitalization between the two groups were really unchanged. This particular study established it as a low-risk and effective option for children who are vomiting. Subsequently, there were other studies, and there was a meta-analysis of various studies which confirmed the therapeutic effectiveness and the safety profile of Zofran for children, and it became sort of a standard way to treat children in the emergency department. IV fluid therapy generally obviously is needed if your ORT fails or if the child is not appropriate for ORT because they're severely dehydrated. When you think about IV fluid therapy, you have to think twofold. One is the repletion of the lost fluid and addressing the ongoing maintenance needs. So it's repletion and maintenance. Generally, for fluid therapy, we start off with a bolus of 20 cc's per kg of normal saline or lactate ringers, and we repeat this bolus until we are comfortable that there's adequate tissue perfusion, which could be urine output, changes in skin, changes in activity, etc. We never use a hypotonic solution to bolus. In terms of maintenance needs, you have to think about the sensible losses in urine and stool of water, and then there's insensible losses through the skin, perspiration, etc., and through the respiratory tract. So you have to account for all of that. There's a very simple way to calculate the maintenance fluids. It's 4-2-1. It's 4 cc's per kg for the first 10 kgs. So a 10 kg baby has 40 cc's per hour of fluid as maintenance therapy. After the first 10 kilograms, the following between 10 to 20 kilograms, you add 2 cc's per kg. So a 15 kg child would have a 40 cc plus 2 times 5, which is 50 cc's an hour. And after, if the child is more than 20 kilograms, you would add just 1 cc per kg after 20 kilograms. So if you have a 30 kg child, you're going to use 40 cc's for the first 10 kgs, 20 cc's for the next 10 kgs, so that would make it 60 cc's, and then 10 kgs for the next 10, between 20 to 30 kgs, so that'll make it a total of 70 cc's per hour. So 4 cc's for the first 10 kgs, 2 cc's for the next between 10 to 20 kgs, and 1 cc after the 20 kgs. Now, appropriate maintenance fluids, it's a bit of a controversial subject matter. I actually didn't realize this until I prepared for this lecture, that clearly there's some controversy whether you want to use isotonic versus hypotonic saline for maintenance therapy. There's risk of hyponatremia with hypotonic solutions in hospitalized patients. It's allegedly related to SIADH, the inappropriate secretion of ADH. On the other hand, there's a risk of hyperchloremic metabolic acidosis with normal saline as maintenance therapy. So clearly there's some controversy in this. We generally don't deal with this in the emergency department because often these children go upstairs and they fight the battle up there. Now, in terms of IV fluid therapy, obviously you're going to estimate the amount of dehydration first, and you calculate the deficit by taking the weight, multiplying it with the percent dehydration, and then multiplying that by 10. So a 10% dehydration in a 22 kilogram patient would be 22, which is their weight, by 10, which is the dehydration, times the factor 10. So their total dehydration is 2200 cc's. The general principle is that you give half of the total deficit in the first 8 hours, and you give the other half in the following 16 hours. So for the first 8 hours, you will give half of the deficit, which is 1100, and you will divide 1100 by 8 and get a rate of 137 cc's per hour. It is really important to remember that 137 cc's an hour is the deficit. You have to add maintenance fluids to this deficit. So for example, if this is a 22 kilogram patient, what would be their maintenance fluid? That would be 40 plus 20 plus 2. So that would be 62 cc's. You add 137 to 62, and you will get your hourly rate for the IV. And that comes to about 199 cc's per hour. Just remember that repletion and maintenance therapies are different. You want to address hypovolemia in patients with repeat boluses of isotonic solution until an adequate urine output has been maintained, and use hypotonic solution for maintenance therapy. That's the end of our lecture. Thank you.